Morning, everyone. Welcome. Hope you guys are doing well. I'm just going to take a minute to get my slides up here. How is everybody this morning? Can you guys all hear me okay? Yes, okay. All right. Good morning. So wonderful to see many of you. I'm going to go ahead and get us started. This is our just-in-time system simulation, using simulation to solve emergent problems. And I'm Kim Stone, and I'm going to give my co-presenters a moment to present themselves just a little bit. For our disclosures, Drs. Reed, Huang, and Kessler consult occasionally for a company which offers system simulation training. They had no part, that company had no part in this presentation. As an overview, we're gonna do these welcome and introductions. You'll get to know us and we'll get to know you. And then we're gonna talk high level about what we mean when we talk about systems focused simulation. And then our methodology for just-in-time simulation. We'll have time to break out into a small group activity so you guys have a chance to have your hand at this methodology. Come back together as a group and talk about what we learned. Then you're going to have a chance to hear from some experts on an elevator pitch. And then it's a chance to practice an elevator pitch. And then we'll come back together for wrap up and some high level learning. So first of all, who are we? So Ashley, can I pass it off to you to introduce yourself?
Thanks, Kim. Good morning. My name is Ashley Kyleman. I'm a pediatric emergency medicine faculty member from Seattle Children's, and really excited to talk more about system sim.
Lennox, I'm going to go to you.
Hey everyone, Lennox Wong. I'm the Chief Medical Officer at Sick Kids in Toronto, and also an intensivist, and been doing sim for a while and really enjoy doing the system sim. Great to see. I see a number of familiar names in our participants, and hopefully familiar faces as well. I'll pass it on to Kim. Sorry, not Kim, Jen.
Jen.
Hi, I'm Jennifer Reed. Great to see you guys here. I'm the Associate Medical Director for Simulation at Seattle Children's, and I'm also a PEM physician and have the pleasure of working with Kim and Ashley in person on many occasions.
All right, Dave, do you want to take a moment?
Sure. Hi, guys. David Kessler, pediatric emergency medicine physician and a vice chair of innovation in the Department of Emergency Medicine at Columbia in New York City. I think it's fair to say, I love IPSS workshops because I'm just as excited to learn from all of you who I know are doing a lot of this work in various ways and share some notes. I've been doing some work in system and process related simulation and a lot of focus on Insight too over the past 10 years. So excited to share our experience.
Excellent. And Kim Stone, also pediatric emergency medicine with a focus particularly in simulation on systems focused simulation. And as Dave had mentioned, excited to see you all here and excited to share with you. We're going to talk about one methodology that we use. I am guessing that you guys have a lot of tips and tricks on this too that we can share and learn from. And I'm going to ask my co-presenters to help me keep track of the chat, and feel free to chime in since I can't really see the chat when I'm in this mode. Now, we want to know a little bit more about you. Go ahead and raise your hand, give a shout out, or write in the chat if you are director, co-director, or lead of a simulation program. You see some of those folks. Excellent. How about a simulation educator? Yeah, I see some reactions here. Awesome. Simulation technician. Great. You may be able to say yes on more than one of these and wear many hats often. A sim researcher. Many of us are sim researchers as well.
Okay, we have people across all time zones too. We got Australia.
Exactly. Awesome. Yay. A quality improvement or a patient safety lead. Excellent. Someone who regularly leads systems-focused simulations. Got a lot of raised hands there. Awesome. Someone who wants to lead systems-focused simulations, but maybe hasn't quite done it yet. Couple hands there. Great. How about anybody ready for in-person conferences again? That's me, definitely. Absolutely. Can't wait to see you guys all again in person. All right, so to get into the meat of this, I just wanted to get us on the same page. This is a very high-level overview of system-focused simulation. When we talk about systems-focused simulation, we're talking about using simulation methodology to recreate complex systems with the goal of identifying improvement opportunities, safety threats, improving the overall system of care to ultimately improve the delivery and quality of care. And this very simple diagram over here sort of identifies that a lot of times with educational-based simulations, we may be focused on the user, on the tools, on the tasks, or on the team. And in systems-focused simulation, we're really focusing on the environment and the processes and the systems that are there to support the people doing the work. Again, super high-level overview of this complex topic. Here's some examples of systems focused simulation. Several of these are titles that are coming from this IPSSV workshop. So if this is something of interest to you, feel free to peruse the program because there's lots of great representation. It can be everything from designing or evaluating new spaces, designing or evaluating tools, processes. Here's a little bit of a view from an anaphylaxis care plan that we have, guideline of care that we use at our hospital. Also, increasingly and wonderfully partnership with existing QI and patient safety tools such as root cause analyses, FMEA. These are all fantastic examples of systems-focused simulation, and I'm sure you have many of these from your institution as well. So what do I mean when I say just-in-time system simulation? I'm talking about a systems-focused simulation that you really need to be completed quickly for rapid implementation, but completely and thoroughly with a deliverable in mind. So a couple examples from our institution. We had a new clinical space open. There was a safety event, and we were called in for what I called our first emergency simulation. Our first just-in-time system simulation was that they wanted simulation to help rapidly design a new process that needed to be implemented within about a week. And of course, with the past Ebola, but even more so with COVID-19, the emerging epidemic and pandemic responses needs additional prepared response. And again, running simulations that week, the very next week, to evaluate and design new processes. So these are just some examples of what we mean when we say just-in-time system simulation. In these circumstances, we have a process map that's quite involved and has lots of great steps. There's no time for all of this prep. You could see up there, if you could read any of this little bit, like sometimes we like to take 6 months to plan for some of these. And you don't have time for all of this, but you have to identify what are the key elements that you do need to take from these, extract from these for these just-in-time system simulations. How do you get the key pieces and the learning quickly to get to your deliverable? And that's what led us to this 3-part methodology. And that's what we'll be spending the bulk of our time talking about. So our simulation 1, really we start with a current state gap analysis. Simulation 2, focus on the routine processes, so routine process stabilization. And then simulation 3 on emergency preparedness. And each of these is really a small PDSA cycle in its own way so that you can iteratively respond to ultimately reach your deliverable. I have the sense that there's some great stuff in the chat. Jen, you want to call out anything you're seeing in the chat here?
I think there were a lot of great introductions. And then I think sort of the comment that it was great that we were called on, that the SIM program was identified and called on for short turnaround needs. So people sort of thinking about how they get visibility on that level for their programs.
Great. Yes, I think one of the, we can talk about more about that certainly, but I think success breeds success. And hopefully from this workshop, you'll get some insights, and maybe using that elevator pitch, you can start to open the door. Great. So we're going to launch into the 3 simulation methodology a little bit more in detail using an example that we had. Oops. There we go. So what do I mean by a current state gap analysis? Often something is in place right now, or some basic bare bone exists. And so we want to use this first simulation to recreate the existing process. And this is just a nice snapshot to be able to start to understand the existing gaps and opportunities based on that future goal. So again, understanding what your deliverable is, what is being asked of you in this simulation, you can have your eye on really evaluating what's working, what's not, and where the opportunities are. The most important part of this is the planning, right? And you really need the same key elements that exist from your long process map. You have to spend time planning for this. And that is with stakeholders, team members, your space and materials, your data collection method and process for rapid turnover, as well as what simulation resources you're going to need. And I would argue that oftentimes this can be fairly limited, and you might be getting asked to do this very quickly. And so you may not have access to everything. Things may be booked or what have you. Leadership team engagement is critical here. And including asking for debriefs with leaders immediately after the simulation, and in our world, in person or virtual, to be able to understand these gaps and opportunities and get buy-in. And then your hospital resources to implement the change. And I'm going to pause here for a minute because I think I was supposed to pause in the slide beforehand, because Dave had a really good point before as we were talking about this. So I'm going to pause, Dave, and sort of throw it to you, so you can sort of take the baton a little bit.
Yeah, I mean, mine's really just a question for you, Kim, or for anyone actually in this room. For those who have sort of been asked, hey, we have a place opening in 3 weeks, or we have a system that we need to deal with. So this sort of rapid turnaround where you don't have a lot of planning time. What is your sort of internal checklist in your mind of saying yes or no to that? And what kind of things do you consider?
Anybody else on the panel want to? Oh, I see Robbie took off our mic. Robbie, do you want to jump in?
Sure. So we do this quite often. And the reason when we say yes or no, it has to do whether it is a organizational safety issue is one of the highest priorities, or if, and I can think of a good example that we did about a couple of years ago, is it a capacity issue in the organization? We had to do capacity testing on whether we could double beds for surge capacity. So it really is it something that is a safety or something that impacts the organization? It becomes the highest priority. And then whoever in my team is the one that's has the breath to take it on, they will take it and run with it and do exactly this process that you're talking about here, Kim, of a gap analysis first, and then move forward from there.
Great.
And one of the
Anybody else
things.
on the panel go ahead, Lennox. Yeah.
Yeah. So one of the things that I think of is it's going to be highly individualized to your organization, your simulation program, and the skills, capabilities, and the history of the team there. So to some degree, when we talk about simulation in other contexts, we oftentimes talk about situational awareness, and you need to have a little bit of a situational awareness of how is simulation seen within your organization, and is simulation the right tool here? So is this something where if you do a very rapid simulation, even a gap analysis, is it really going to change anything? And how do you have a history of having done things and been successful, even small successes within the group? Or is this going to be seen as, you're kind of an ancillary service, you're here for PR purposes, you're here to really just put the icing on the cake and nothing's really going to change? That doesn't mean necessarily that you're not going to do this, but it's important to go into this with clear expectations of how SIM is perceived by the key influencers, the key leaders in your organization.
And along that building, oh, sorry, Dave, go ahead.
No, just in the chat, Ellen also put in loving the 3 SIM idea and a question of what resources or margin do you need to be able to respond quickly?
Exactly. Ellen, that's a super important point. And that's where I was going to pick up what Lennox said, which is that you need to know when you're being asked this, because of, I just sort of said what you need for the current state gap analysis, and you know what you need for your systems focused SIM. You need to know that, just like Robbie also said, you have the hospital leadership buy-in. This is important enough that you are going to be able to get the resources needed to do the rapid change that's needed. And so that's really, when Dave asked the question of me, that was what I said, that's the most important part. Who else is supporting this? Not just the folks who are asking, and what resources do they have to actually make the change?
And Kim, maybe jumping ahead here, but those resources, I think both about the resources you need to actually do the simulation. So can they commit what you need to actually do the sim? And then also, are they willing to commit the resources to do something about whatever you find afterwards and actually fix it before whatever it is goes live?
Yeah, exactly. It's easy to go in and do the sim. It's the part afterwards that people don't always think about. And that's what you want to make sure you have the resources for. So I'm going to jump back to our example, and our example is with our COVID-19 vaccine clinic. Many of you probably have been doing SIMs related to COVID-19. We were asked to help rapidly assess an existing space and create processes around the COVID vaccine clinic. And we were asked in a very short period of time, as everything with COVID has happened, right before that the hospital was going to have to be giving vaccines. So we did a 1-hour prep meeting with the key leaders that had asked us. And again, really focused on what are the resources we have available to us, because we had a suspicion going in that the existing space that was used for our staff flu vaccine probably wasn't going to work. We were going to evaluate it, but we needed to know that if we found out that we needed a new space, would they find us a new space? Would we have building and engineering? Would we have signage? Would we have all of those supports that sometimes we don't think about as clinicians if we are clinical staff? So we did a 1-hour prep meeting with all of that planning. We did performed a 1.5-hour simulation. This was a super simple simulation. We probably had, I want to say, 6 of us present at this simulation. This was using the existing space, using single patient flow with a very basic process map. You can see I have a picture of it up here. Very basic process map, using what we understood was going to be needed in the steps for administering the vaccine. We collected some cycle times. So that way we had some preliminary data to understand relative to a scheduled template that they were thinking about. The study portion is we debriefed this as a group using systems focused simulation debriefing, the PSI methodology, and I've put the reference there if anybody's interested in learning more about that debriefing methodology. And the focus here was on big pictures and big gaps, right? We really kept this at the 10,000 foot level. Did this space work? What else would we need? All those pieces. And then the ACT piece was, again, right after the simulation, we had a leadership team meeting with hospital leaders who could put resources where we need it, where we brought to them our findings, what we thought the next steps were, and how to move that forward.
And Kim, I just want to emphasize, I almost feel like that's step 1 when you say, yes to the project, is understanding what the levers are at the end of it, what's going to be done, what's not going to be done. Can anything be done at all? Otherwise, it's sort of simulation as exhibition or carnival, and not actually changing the system.
Yeah. So that led us to routine, our second SIM, which was routine process stabilization. We incorporated the learnings from SIM 1. Changes have to happen, and then you start to plan for routine processes. You can add some minor complexity in there, but this is not the emergency, right? You want to think about the start of your process or project and the ending. And you want to think about what are some common non-routine but not emergent situations that might be part of this to kind of understand the nuances. And then you need to think about what are your additional, who else are your additional participants that may now be needed. So again, it's sort of a layering effect, right? When you get at this ask, you can think of this ask of to do this thing. You could think about all of the parts that need to be added in there, but it's having this iterative approach that is helpful in sort of layering it on so that you're taking things in bite-sized chunks. You might need additional stakeholders, and it's also helpful to anticipate some possible findings that you might have. Oh, this could go wrong, this could go wrong, this could go wrong, because then that's going to also affect who you want in the room, either observing or participating or part of that leadership team meeting. So coming back to our vaccine clinic example, we had an hour-and-a-half prep meeting to plan for this. And the 3-hour simulation, we did actually have a new space. So we were evaluating that new space and the flow within that space, as well as unidirectional flow coming in, getting vaccines, observation space, and exiting. So that way it was nice and streamlined. Our goal was to maximize the efficiency. And again, focus all on the routine process, the start of the day, the prepping of the vaccine, the patients coming in and queuing, checking in, giving the vaccine, the nursing staff documenting, the checking out period, all of that. And we had some real patient volume data based on what they thought the schedules were. So we kind of kept that tempo going during parts of the simulation as we built up to that. We again debriefed using the systems focused debriefing methodology. And we did this both within the simulation. We had pauses in the action. So where we could make some small changes then, even like, okay, let's rotate. We're going to put these two stations next to each other instead of this far apart. Could do some very quick changes right there. And then again, the big end of the event, debrief, and the findings escalated to the leadership team. And then the vaccine clinic team and the hospital supports took and would implement the changes that we identified. Which led us to our third and final simulation, which is emergency preparedness. And this is your opportunity to stress the system. You think about the high-risk situations and the high-risk conditions that might be related to this process. And again, layering on now who else needs to be involved, and then how do you prepare the team? Again, this is systems-focused simulation. We don't surprise our teams with this. They know going in what's going to happen. And you want to think through what are all the things that you need and people there to make sure that you can get an accurate assessment of how the team would function. And for us, we again had a 1.5-hour prep meeting. This was a 3-hour simulation. We started with some just routine process and let the team get into their flow. We identified that really sort of just the like, I'm dizzy or I'm anxious patient is sort of one emergency situation that they really wanted to evaluate. And then the next, of course, was a full anaphylaxis with a code team response and transferring to the ED. So we did all of that. We again used the within sim and at the end of the sim debriefs and huddled with the leadership team after the sim for some changes that needed to be made or additional information or job aids that were needed. And then 2 days after the last simulation, the vaccine clinic opened smoothly. So coming back, that was sort of a high-level quick overview of our 3 simulation methodology with our PDSA cycles. I'll pause there and see if there are any questions or thoughts or anything from the chat that my co-panelists want to bring up.
And there's some interesting chat around, you know, what are enablers for this to go as smoothly as it did for you. And maybe one of the things that I wasn't involved, obviously, in your design of the COVID vaccination clinics, but one thing that we found in general with this sort of thing is to have people who have on the ground operational experience. So like if you've got teams that are completely naive to process and operations, and you're trying to introduce a brand new team to something they've never done before, it's going to add an extra challenge to run a simulation, because they're not even like, there's nobody there who does it, who knows even how you might run the place. So I don't know if you can comment on that, like how in the teams that you ran this through, how much on the ground operational experience would they have had, like some of the participants?
Jen, do you want to take that? Or Ashley?
Sure. And Lennox, I just want to clarify, when you're saying operational, are you thinking of actual like the operations of the clinic, or are you thinking more operational as far as simulation goes?
Exactly, more like the clinical experience. So for instance, when we launched our pediatric clinics, we had our peds folks who hadn't done this chatting with the adult folks who've been doing this for weeks and weeks and weeks to understand flow and complexities and how it interfaced with the EHR and all these other things. So you can imagine if you had two teams that were completely naive to this, and then you throw a simulation there, you may not actually get the most useful information.
Yeah, I'll start. Ashley, you can add on. I think one of the things that was critical for us, and I see that question coming out in the chat as well, the reason it was a success was because we actually had people with a lot of experience in both of these realms. So the folks that were participating had a tremendous amount of operational experience and sort of how you problem solve when you're bumping up against something that doesn't work operationally. So they already had in their mind like a toolkit of different ways they might overcome various barriers. And so there was that group of folks that were participating. And then I would say that probably the bulk of people, or at least many key people, had already been involved in system simulation in our organization, more along the lines of that massive flow sheet that Kim shared with you earlier, where we very slowly worked through things. So I think that was key. People had some idea of what we were going for from a sim perspective. People had an idea of how to overcome barriers when they hit operational issues. And so it was really bringing that together in a tight time frame.
And then because there inevitably are going to be some attendees who haven't been to an event before, laying out the objectives and the goals in the introduction to the event and making that very clear to the participants, as well as the timeline and time frame you're working within, helps to get other people oriented to what your objectives are.
Yeah. And I see the question in the chat, and we may have kind of addressed this, Tom, about what's unique about our work culture that helped make this a success. I think that we do have the benefit that that our organization is used to doing simulations for systems improvement. So we have that. We also are traditionally a lean organization from the Toyota methodology. And so this idea of sort of rapid cycle, in fact, Dave was saying we could call this a rapid cycle system simulation, which it really is too. It's another way of thinking about this. That organizational idea around rapid cycle improvement also is not a novel concept. So when we meet with the leadership team, a lot of times we talk about it in that same way, just like you would do this in a rapid cycle improvement project, right? Who's available to us? All right, so moving on. Now let's switch to emergent problems. What problems are happening in your hospital right now that you could see using just-in-time simulation to address? We'll just take a moment. Feel free to unmute yourself and share with us, or put it in the chat. What are you seeing? What are some of the problems? Oh, and Robbie said, yes, you partner with human factor engineers. Yeah, that's great. We haven't had as much experience doing that, but that is key. Preparing for bed pressure surge and RSV. Yep. Any other emergent problems? Nursing shortages, yes. We're all experiencing that. Mental health emergencies. Yep. All right. So think about ones in your organization. We've done a little bit of this work too that you guys are going to do in your small group. So we're going to be breaking into 3 small groups. And And your group is going to be presented with a timely problem that could be addressed with systems-focused simulation. It may not seem obvious just looking at the problem, how you would use systems-focused simulation, but that's part of this too. And your goal is to pick an approach to the problem that your group wants to pursue. And then walk through the 3 simulation methodology, talking about what's the deliverable, who are the key stakeholders, what do you need to set the simulation up for success? And then how are you going to collect your data? How are you going to report it back? Really walk through the mental exercise. And we know that we don't have all the processes, but we can think through what some of the routine and some of the emergent processes would be. We do have a worksheet, and of course we're all virtual, so we can't just pass that out to you. We're gonna put in the chat, each of our leaders will do this. We'll put in the chat a copy we'll copy the Google link to this Google Doc. And then we ask you if you want to use the worksheet and not just reference it, but if you want to actually write on it, to download it onto your computer, so that way we're not all seeing each other's. And then we'll be using a screen as well. All right, so I believe what's going to happen now is you're going to be invited to join a small group. You guys are going to be randomly assigned, and then we'll see you back here. I'm going to say let's do this for 15 minutes. So we'll come back here at 10:47. Hi, everyone. As you guys are coming back, I'm going to share my screen again.
All right, Kim, I think we're all back now. Well, I hope everyone had a chance to start to dive into one of the topics and think about how you could use simulation in a rapid process structure to tackle a challenge facing your hospital system. We had a great discussion in our group about cybersecurity. And so I'll first turn to Lennox and then we'll go to the other groups to learn a little bit more about what you've been discussing. Lennox?
Sure. So, we had a really interesting discussion because I think that one of the key learnings here is that
Lennox, I think you're now muted.
There's an accidental self-mute.
Self-mute. All right, there we go. So we had a great discussion, and I think one of the key learnings from this is that when you start to take a systems lens to things, there are so many connections that you can start branching out. And that first question about narrowing is a really important one. So the way we started here is we took the idea of overarching problem of cybersecurity with a potential ransomware attack, and really start to realize that you could break that down into upstream prevention at the phishing email type level, or looking at risk mitigation, which might be downtime prep. And then, or the third is just gaining an understanding of all the networked activities inside. We went with the risk mitigation approach to try and decrease the impact of the ransomware. And then when we started to go through the stakeholders, we realized there are so many stakeholders in the hospital that would have an interest in this. It's actually fairly challenging to do that. But we came up with a broad list of stakeholders, both people at the front line, that sort of the obvious would be in the information services, IT type world, then the frontline clinical, and then some of the back office, and realize that there's interconnections outside of the organization too. So depending on the scale that you're doing this and the importance of it, you might need to bring in external partner organizations. We didn't quite get much further beyond that, but I think even just that process of narrowing an overarching problem to something that's a little bit more manageable was a great start. And probably where, if we were doing this in our organization, we would try and narrow it even more, because and that's certainly what we've done with our chief of cybersecurity. He's run some simulations already, but they've kept a very, very narrow focus to it, and they're kind of repeating it over and over.
Certainly an interesting and complex topic. It's great to think about how we can add a simulation lens to it. Kim, I'll turn to your group.
Yeah, I'll report out for our group. So we also had a nice discussion. We started with our workforce shortages and really kind of brainstormed, how does system sim help? And we talked about evaluating different models of care, and as well as sort of demonstrating some of the risk using systems-focused simulation, as well as evaluating potential training programs that are being used to help people float into areas with workforce shortages. So again, different ways to address a systems problem that maybe at first glance doesn't definitely have a simulation focus. And much like your group, we didn't get very far, but really one of the things that we talked about that is an important point is that when you are starting with that current state gap analysis, it's possible that that can be, instead of a full simulation, either a modified simulation or observation too, right? Just knowing what it is you're observing for is super important, and with the same way of thinking about it for SIM, and also the deep dive into the different folks that need to be involved. So great discussion.
Yeah, certainly that first phase can take on many different forms, whether that's a tabletop exercise or an in-person event or a deeper dive looking at observations. Last but not least, Jen and Dave, your group.
Yeah, for us, we're really fortunate that Ingrid offered to do a quick summary. And I'll just put out there that I think when we first started talking, it sounded like what we were talking about was a training use of simulation, but we were able to take it up to the higher level of what I would really say is probably in the realm of workforce shortage and trying to figure out how you actually have a training program. Go, Ingrid.
Awesome. It was helpful to describe to the group sort of this is the globular enormous problem that's being asked, and how do you break it down into pieces that are more approachable or manageable. So as Jen had just said, what sounded like training shortage, actually let's pick one specific little example of, like, there's a new defibrillator coming in. So how do we test people on setting up the ZOL? And then when we got to our, what's the systems test? What's the deliverable? Like, can they set up the ZOL correctly? Do we need to create job aids to do it? We got as far as which stakeholders we would need to have there, from the different interprofessional teams to experts who would be able to make sure that the new equipment works. People understand how you're supposed to use it. They can troubleshoot problems. We didn't actually get any farther into the next columns with it, but it was very, very helpful in the group to take what many of us have is like these enormous amorphic problems that are hard to approach and figure out how to make it into a little chunk that you can actually assess. And maybe the ask sounds like it's, in this case, a training problem, when really there are system safety issues that can be identified and fixed with it. It's on us to learn how to frame it and reframe it for the leaders or the people who are asking for it, rather than doing what they are asking for, help them understand what they actually need to be addressing, I guess, even though the ask maybe do this training, but really what they're after is system-wide, safety-wide, how do we make this more effective?
That's so important to consider how you can optimize your system to help support your staff in their everyday work and to really focus on your deliverable from a focused event. All right, next we're going to turn to Lennox and Dave to talk a little bit more about elevator pitches.
All right, great. We're having, our panel is having a little sidebar conversation, just given the timing and the way the discussion has gone. I think what we're going to do now is just is to introduce the concept of the elevator pitch and show where, how you might use this to initiate a conversation about system simulation in your own organizations. So a couple of quick things. First off, why don't we do this by reactions? So you can just do a thumbs up or something like that. How many people have heard of the concept of an elevator pitch? Just offer up like a little thumbs up if you've seen it. Yeah, a bunch of thumbs up there. So, this does originate from, the venture capitalist entrepreneurial world, where the idea was that somebody who's got an innovative idea is going to try and capture some funding from a venture capitalist during the course of an elevator ride, which is about 60 seconds, depending on how tall your building is. And the real purpose of this is to connect with an influential individual, start to get a commitment to a future conversation. So you really have a very short period of time to introduce yourself. And I always tell people you want to decrease the cognitive load for that individual you're trying to connect with. let them know who you are. So you're trying to get that influential individual who does a certain thing, thinks a certain way, is in charge of a certain group of things, to start shifting their mindset to maybe think a little bit differently by listening to your pitch. So if we go to the next slide. So that's the cognitive load drop, right? Introduce yourself, let them know what your connection is to the organization, and what the connection is to the particular problem you're interested in tackling. So let's say it's a cybersecurity thing. You are a frontline individual, you've seen firsthand how important our systems are, and you're a little bit concerned that you're hearing about this and seeing this in popular media that some places have been under attack from hackers. You're wondering what the impact would be on this organization if that were to happen. And by the way, I think we have a way we can prepare our organization to do this. So you identify a goal, a problem to be solved, at the same time, just drop a hint of a potential solution to that problem. In general, you don't want to ask for money on an elevator pitch because it's a bit forward, frankly. There are a few exceptions to that, but more or less what you're trying to do is to get a commitment to a future conversation. So can we have a real life meeting at some point, or a virtual meeting? Can I bend your ear about something? Is it all right if I drop you an email with a few more details and then we can talk about it further? And there's phrases that you can use to really just open up that conversation, right? Like you want to turn the problem from something that's really negative into a bit of an opportunity. And phrases like, imagine if we could solve this without too much trouble, and at the same time improve morale throughout the organization. Can I tell you about something? Is it all right if I share something with you? My fellow panelists have done versions of this and also taught versions of this. Anything I've missed in a very quick overview to the elevator pitch?
No, I think it's a great job. The overarching I would just add, Lennox, is what story are you telling? Because again, from like that venture capital world, people always say, you start with a pitch deck and then they're like, but it doesn't matter if you do the pitch deck. And actually people get super bored if you do the pitch deck in order. So in elevator speech is the same way. That CEO has heard 1,000 people approach them. So the most important thing is authenticity and what's your story, and just tell your story. And as long as you sound authentic and passionate about simulation in this case, I think that's what comes across more than anything else.
So what we had originally planned is for us to break out into small groups again and practice elevator pitches, either linked to the problem we had identified or perhaps a problem in your own organization. And we have a little bit more refinement of this. I think just given where the discussion has gone up until this point, we want to offer the group, or maybe the small groups, the opportunity to continue the discussion around the problem they selected, to say, all right, so now how do we refine our approach and start thinking about a 3-sim model? Or alternatively, you could do the upstream thing and start to work on the elevator pitch. So you've already got an idea that this is what you want to work on. How do you frame this to somebody of influence? So Kim, do you want to kind of give us a bit of direction on this? Do we want to do this as a large group vote, or should we break out into small groups and work it out?
Yeah, I think we should vote a little bit, but I would also throw in a third option, which is that, just to throw a wrench in there, which is that, do folks want to just have a little bit more conversation about this 3-step approach, or ask questions of the programs that have done something like this? Just a little bit more of the sort of panel discussion sort of component. So, so what I'm going to do is real quick ask for hands. Actually, I'm going to get you guys all to unmute yourself. Go ahead and unmute yourself right now. Everybody unmute yourself. If you want to go into the small group and do some practicing elevator pitches, say yes now, cheer now.
Woo. What are the other options, Kim?
We're going to do 3 options. That's a good point, Nancy. I didn't tell you all your options. The 3 options are small group elevator, small group work your problem, large group panel. Those are going to be your 3 options. So I'm going to do it again. Small group elevator pitch. Give us a yay right now. Use verb. Go ahead. Scream.
Yay.
Yay.
Small group work your problem. Large group panel discussion.
Yay.
Okay. Large group discussion wins. All right. All right, gang. So now, just-in-time decision-making as a just-in-time workshop. Meta. Absolutely. All right. So panel discussion. Now you've got to ask some questions. I'm opening it up.
As a total newbie to this, can I hear a little more from any panel members, either with an example or just a little more description how, I'm not totally clear on how to break this into the 3 sims. I know we talked about it, but I need a little more concrete discussion to help me get a better understanding of that.
I could share one approach that we did with a serious safety event. So, and it just gives you a little, it's not a perfect match to the 3 sim model because this is, you know, different organizations and we've each tackled it slightly differently. But we had a series of serious safety events involving G-tubes. And the thing I've been sharing with my colleagues is that every single hospital I've ever been at, there have been safety events related to either G-tubes or NG tubes. And we know that to be a pretty pervasive problem. But in our case, we had a number of safety events with G-tube dislodgement. One in particular where, you know, it had dislodged and ended up causing pretty significant peritonitis that was life-threatening in a child. And we knew we had to do something differently. And when we approached this, simulation wasn't an initial part of this. We had our usual serious safety process with the quality safety individuals, the clinical team. And then we realized that there was an opportunity for simulation to be woven into this. And so the first part of this was there was a current state analysis to just that combined with process mapping to understand all the different permutations for what happens when you have a G-tube that becomes dislodged. And through that, you start to realize, oh, well, this is part of the issue is that it's not just 2 or 3 different ways. There are 3 different services, 3 different approaches, 4 different approaches to confirming location and placement. Depending on the time of day, this might happen here, depending on where they come into the hospital, whether it's at the you know, emergency department versus a clinic versus an inpatient, things were different as well. And so that is where there was a simulation that kind of looked at understanding the current state of what happens when you dislodge a G-tube. And we did more than one. Then there was work done to create a unifying approach and pathway to G-tube dislodgement that I'll say didn't initially involve simulation in this because it was really more getting stakeholders. So we identified all the stakeholders who might possibly be involved with this and brought them together in groups and started to talk through what the process looked like and operationally what it might resemble. There was then work done to create a unifying pathway, and this is where simulation again came through, and we ran multiple in situ simulations to test that to test the pathway. And it was, you know, there was a bit of a go, no go type thing. So like we would not implement this pathway without having it gone through all of these simulations with the system lens and then refining that pathway to the point where it could then be launched. And after it was launched, we ran another set of simulations again in situ with a finalized pathway just to test it in different areas of the hospital with different care teams, mixes of learners and staff people to see that it was error proof. So that's sort of almost like a 3-step approach. It was perhaps not as quick and just in time as the vaccine clinic, but it was certainly a whole lot faster than some of the past work we might have done related to this.
This is Emery Monachina from CHOP. I can share an example if that's okay. With the pandemic, our hospital was asked to do drive-up COVID-19 testing for our children. And our first sim, if I think about it in the way the 3-step you're referring to, our first sim was basically a tabletop exercise where a group sat and they wrote out a process map, what they thought the process would look like, who would be involved, all the different, this was truly interprofessional sim. We had everyone from security, physicians, nurses, IT, infection prevention control. So after then we actually went to our site, one of our ambulatory sites in the parking lot, set up our tents, set up our cones, had, I brought mannequins with me. We put them in a car. We asked a simulated participant to play the role of a parent, had everybody with all the equipment that we needed, all garbed up, went through what we thought would work, what we had designed on paper. We found many things needed to be changed as far as the flow of the patient. So after maybe 1 or 2 run-throughs, we made the changes right there on the site. We ran through it again. It seemed to work pretty well. Then we did a 3rd time. We said, well, what if the nurse or the person doing the swabbing can't actually reach into the car to get to the patient? And what are we going to do if we have to take the patient out of the car? Because that was not in the original design. So it wasn't really an emergency, but it was what if something went wrong? So then we went through a sim with that case scenario. And eventually we ended up setting up drive-through COVID testings and probably did 5 different sites. And each time we opened the new site, even though we had the system down pat in the first site, we did simulations at every following site to make sure that the process we designed in the first site was actually going to work through all the other ones. So it's a neat to be involved with. Very cool.
Anne-Marie, thanks for sharing that example with us. I think listening to you, I just realized it's sort of challenging. I think maybe one of our assumptions. When I think about simulation, I often think about me in person, and it's like all the people physically and they're going through things. And I really love how you brought up sort of work that can happen ahead of time. So a tabletop or the process mapping and some of the pre-work, which can then really maximize the time that you have together in person. So I think for a lot of these where you're really trying to do things in a short period of time, if there can be a little bit of pre-work where you can think about what that process map is or who the right people are, doing some of that legwork ahead of time, it really will just help focus your in-person time and really help you get at the most important questions there.
Other questions?
This is Anne. Sorry, I don't think I have another question, but I think the example, I think we're all probably facing, I can't speak to all, but many of us are facing nursing shortages and real challenges. So I think it would be even interesting to think after this is what are ways that we can think about using simulation or the collective expertise on everyone here to approach this, because I think it's not going to get better anytime soon. Is what it seems like, potentially worse. And I think it's a huge topic that we need to think about it, how we can address it, and whether, I'm just imagining that I'm going to end up being on the front line again at some point.
One very focused example we did of that here was looking at changing our model of care in our urgent cares. Instead of having 2 RNs having to go to 1 RN, 1 MA, and then how do you respond to medical emergency situations when you have different staff with different skill sets, and thinking about how you restructure your teams and recruit extra help in order to still be able to safely care for those patients. And so if you're having to change your team structure and model of care in one area, that is one place where you could employ simulation in this way. And we may have other examples from across the panel.
So I think that's a great example, Ashley. And it also at the same time highlights the importance of being able to narrow your focus for a just-in-time sim. Because the problem of nursing shortage is like a huge problem. You could look at the very tail ends of retention. You could look at the model of staffing, or you could look at the front end in terms of the uptake and recruitment and rapid onboarding. There has been there's actually some literature out there around the rapid onboarding of nursing, and there's business cases for sim centers that have been based off of that. So being able to shorten down that onboarding time and get people through the use of simulation right up into the clinical context as fast as possible has been shown to drop costs at an organizational level. So that's one particular example. And then Ashley had a great example around changing up team models.
I think that this conversation really strikes home to me in a conversation we had just with nurses that are already within the organization who have not been at the bedside for a long time, but to simulate what type of activities they could be brought back to the bedside to perform and how to very quickly ramp them up to speed so that they can assist with the care at the bedside. And this conversation has really triggered that I think there would be a goldmine there that our simulation team could perhaps help with in identifying how to quickly, those people are already in the system, they're already there, they're already employed, but what are the tasks that they could quickly be brought up to speed with, even if they haven't been at the bedside for a couple of years or 20 years, what things could ramp up quickly that they could really assist with.
Ellen has dutifully had her hand up for a little bit, so I'm going to pass it to you, Ellen.
So I have a question, sort of more proximal in this process, which is, what do you guys think were the capacities or the abilities or the resources of your SIM program that allowed you to respond quickly to these kinds of requests and opportunities?
I can answer for the vaccine clinic and then I'll pass it. I'll get that started. So one is really thinking about what do you really need from the SIM program, right? For the vaccine clinic, we didn't need very much. And we didn't use any mannequins. We used a volunteer, person going through the process. And what we used our SIM program for was some of the sort of support resources. To be able to, we use barcode to capture events. So people who are observing, not events, I'm sorry, opportunities and threats. So we had the SIM program sort of set up the structure around the event so that way we could have a way of capturing the debrief information and things like that. But in terms of like technology resources, it was very limited. In other cases, we needed more. And I'm going to throw it to Jen to sort of say, what do you think bringing proximally to answer Alan's question, what do you think the capacities are of the SIM program that make this successful?
Yeah, I think you started there, Kim. And one is, I think if you're trying to do something in short order, it's low technological complexity. I think the other piece is really having a structure set up for issue capture that isn't labor intensive. So you got to have some quick way to generate that list of issues and be able to pass it around quickly. So it's not relying on like us in the old days where you had like 3 people typing madly for hours on end. Then I think in all fairness, you need to have enough people in your SIM program that have done system simulation, that have enough free time, that have, they've been given enough FTE that they can actually sit here and when that problem gets thrown at them, have enough space to be able to think about how it might be tackled and organize it. I think that's a huge one. Anything anybody else wants to add?
I think the more narrow and focused something is, the fewer people at times that you really, really need to run with it. And that's what I posted in the chat, is it can be a very, very quick, small group if you've got people with capacity and are able to just drive with it. I think we're kind of nearing the end of our session. Is that right? It's hard to believe how quickly it went by.
We are.